Alright, for this video we're going to cover musculoskeletal and endocrine medications that we did not cover in class. So we're going to start with musculoskeletal. First I'm going to skip ahead a couple of slides and go to osteoporosis first because I feel like it'll make things more understandable later on. So first off is you have your osteoporosis. Basically what's happening is the bone formation is not adequate enough to warrant, proper bone structure. So bone's going to be brittle, bone's going to break, leading to fractures. So you're going to try to treat it by somehow you want to increase your osteoblast production, which is going to grow more bone cells, and then decrease your osteoclast, which will decrease the breakdown of the bone cells. To do this, you're going to need it's going to require a lot of calcium. Also, a lot of calcium requires a lot of vitamin D, because remember, you need vitamin D to absorb your calcium. So it's very important you have both. One of the first medications you can have is raloxifene or Evista. This is the selective estrogen receptor modulator. So basically what this means, it's going to affect the estrogen levels in the body, predominantly in postmenopausal women. And it's going to help decrease the body's ability to break down bones, thus leading to stronger bones. So it's going to be stopping your osteoclast production, which will end up leading to stronger bone formation by just letting your osteoblasts keep building bone, building stronger bones. So the other thing you need to be aware of is if you're going to be breaking down the cycle of the bone destruction, you're also going to want to try to increase your own calcium and vitamin D intake so your osteoblast can build the bone and build it up. The problem with these is it's kind of the same contraindications as birth control, so it's going to potentially lead to blood clots. So if they have any sort of blood clot disorders, DVTs, anything like that, embolisms, strokes, it's going to be contraindication. Also because you're basically affecting the estrogen, it's going to be category X for pregnancy. It can also lead to liver and then liver disease, so hepatotoxicity, and also breast cancer. Alright. Next thing we're going to talk about is the bisonophates, or Fosamax. Fosamax, basically what I was talking about before, is it's going to increase your osteoblast production. By increasing your osteoblast production, you're increasing the amount of bone the body creates, and you're also going to decrease the osteoclast, breaking down the bones. So Fosamax, that's what Fosamax does. So what you're going to need to know is it can also lead to ended up lowering your sodium levels also. But with this, you also have to be aware of taking enough calcium and vitamin D for your osteoblast to actually be able to build the bone. Without the calcium, no matter how much Fosamax, how much osteoblasts want to build more bone cells, they can't. The contraindications with Fosamax is that they can lead to esophageal erosion, basically heartburn, and so a huge contraindication if anyone has a history of GERD. Any time for NCLEX, if someone has esophageal erosion as a side effect, they need to sit up for at least 30 minutes after they take the medication. It can also end up leading to hypocalcemia, low calcium, I had to make sure I pronounced that right. It can also lead to constipation and abdominal pain, basically from affecting the calcium ions in your GI tract. Next is going to be calcitonin. Calcitonin is basically calcitonin which is derived from salmon, from fish. Basically what the calcitonin does, it's your body's natural hormone that kind of increases the osteoblast production, so it's increasing that bone growth, and then decreasing the osteoclast. So it's like this kind of works the same way as your Fosamax. It's just a little better, more natural way to do it. It might not work as strong as your Fosamax. On the flip side, you can also have a lot less drug interactions. But it's contraindicated in kidney patients, so any sort of HD, dialysis, or any other medications that can affect the kidney, you don't want to take calcitonin. Usually calcitonin can also be used as a nasal spray, and any sort of nasal sprays, remember, you have to use one nostril then the other, and vice versa. But it can also lead to secondary infections in your nasal tract. There's also drug interactions by decreasing your lithium levels. Lithium, remember, is the anti-bipolar medication that we're going to talk about a little bit, but you can look into it in your book and figure out what that does. So the big thing with this is, again, you have to increase your vitamin D intake and increase your calcium intake for these medications to have an effect. Alright. Then you just have calcium supplements, which again, basically any sort of Tums, anything like that. Which the problem with those is you can lead to hypercalcemia, high calcium levels. And the problem with that is you can get cardiac problems, because remember, your heart is a muscle, so the calcium is used by muscle cells in this calcium ion channel pumps to get contractions. So if you have too much calcium, you can actually overstimulate your muscles, leading to an increased blood pressure, increased pulse, and also muscle weakness and cramping, because the muscles get overstimulated. They don't know what, they can't quite keep up. It can also lead to constipation and just GI problems and all. Alright, now we're going to backtrack to the beginning of the PowerPoint and talk about rheumatoid arthritis. The reason we talk about osteoporosis first is because rheumatoid arthritis uses glucocorticoids, which are also used for gout. So I want to try to explain the symptoms together. I kind of had them separated in the PowerPoint. I apologize for that. So, rheumatoid arthritis. Rheumatoid arthritis is basically an autoimmune disorder where your body's own antibodies attack the joints of the body. And it will lead to the destruction of the joints, leading to pain and inflammation. So you're going to try and treat this in several ways. You want to control the inflammation, which will also decrease the pain overall, but also stop the breakdown of the joints that they have. So you're going to try to give them some immunosuppressants to stop their own immune system from breaking down their joints. So how are we going to use? We're going to use NSAIDs, which are non-steroidal anti-inflammatories. We already covered those in the pain PowerPoint earlier in the semester. But some of these medications are used continuously, so that's why you always have to make sure if you don't understand something earlier on, you need to try and study it now. Also, you're going to use glucocorticoids, or steroids. So they are immunosuppressants. We're going to cover those in a little bit when I'm talking about gout. But for right now, you're also going to use disease-modifying anti-uremitic medications, DMARDs. These are going to be medications that are going to be specifically used to try to control the specific antibodies that cause rheumatoid arthritis. So basically what these are going to do, these are going to be immunosuppressants. They're going to eventually slow down the breakdown of your own body's joints. So the first one is rheumatoid arthritis. Methotrexate. It's daylight savings. I didn't quite sleep too much. Methotrexate. Methotrexate, first of all, category X for pregnancy. Huge risk for pregnancy. It's also going to lead to severe liver and kidney toxicity. This is also used for a chemo medication. And you remember from the previous discussion, chemo medications decrease the cellular production, the meiotic cycle of cells, basically causing cells that grow fast to be inhibited and grow slower. Liver and kidneys have fastly growing, replicating cells, so it's going to affect those. It can also lead to stomatitis and GI ulcers. Stomatitis is basically ulceration in the esophagus. GI ulcers, look out for upper GI bleeds. Signs of an upper GI bleed are one, could be anemia, weakness, but the main indicator is going to be either emesis of coffee ground stools, which is the old blood that's been sitting in the stomach. It's kind of been oxidized, broken up, and then thrown up, or black tarry stools. Same concept. The blood is going through the GI tract, and the iron in the blood gets oxidized, leading to that black, kind of rusty, maroon-colored stools. You'll also, of course, see a drop in their H&H and signs of anemia. So other things you have to be aware of with this is you want to be aware if they have any sort of history of GERD, any history of ulcers, any history of kidney or liver disease or complications, they can't take this medication. Another thing that's going to be using the immunosuppressant, helping decrease the breakdown of your body's joints, is going to be Intercept. Intercept kind of works the exact same way, but also has a slightly fewer side effects, but at the same time even stronger side effects. is for both of these, you have to be a huge risk for infection because you're using immunosuppressants. You're going to suppress the body's own immune system, thus leading to just a secondary chance of infection happening. So, risk for infection is going to be for both of these, and any immunosuppressant. Same with your cancer medications. Secondly, can lead to Stevens-Johnson syndrome. Stevens-Johnson syndrome basically is shown as a minor rash, which then gets spreads up the entire body. And what happens is the skin gets your body gets hot. Your skin basically starts to overheat and peel off. It's very quick. It's very hard to treat. It's very life-threatening. So if you have a patient who's on Entanercept or anything that causes Stevens-Johnson syndrome, that minor rash you see in the beginning is going to be your huge major side effect to be aware of. Also can lead to heart failure. So remember, review your signs of heart failure in a book, and also be aware if someone has any sort of cardiac complications, if they already have hypertension, if they've had MIs in the past, or they even just have heart failure, they probably shouldn't be taking Entanercept because it can tax the heart. Alright, just flip around here. Next, we're going to talk about anti-gout medications. Anti-gout medications, basically what's happening in gout is kind of it's almost the same premise as rheumatoid arthritis. It's going to lead to inflammation, and inflammation is going to be due to the deposit of uric acid in your joints. Uric acid is basically crystal formations. That's going to be very painful. So again, you want to give them pain medication, anti-inflammatories, and then medications that will hopefully decrease the gout. So the two medications we're going to be talking about are going to be allopurinol and probenecid. Allopurinol basically works by decreasing uric acid levels in the body. It works slowly, so it's going to be more of a chronic control medication, not for someone who's having an acute gout attack. So it takes about 4 or 6 weeks to take effect, and it's going to slowly start decreasing uric acid levels. Try to get your body to maintain and keep going and not just depositing uric acid in the joints. Just a second here. Very benign side effects, but most commonly, what you want to be aware for this is going to be kidney failure, renal failure, because you are going to be affecting uric acid output. You're going to be affecting the kidney's ability to secrete uric acid, so you're going to be taxing the kidneys, doing things more than they would want to. Remember, signs of kidney failure, you're going to be monitoring your BUN and creatinine, just like with liver failure, it's going to be your AST and ALT. Labs are important to know. Next is going to be probenecid. Probenecid basically works the same way, but it stimulates the kidneys to excrete that uric acid a lot quicker than the allopurinol. And it also can be used minorly in renal disease, but at the same time, you're going to be taxing those kidneys, thus causing complications. These are all going to work by decreasing uric acid levels, but at the same time, you're not going to be controlling what's the other problems happening is the inflammation and then the pain relief. Again, you're going to want to give NSAIDs, but another stronger anti-inflammatory is going to be glucocorticoids. Glucocorticoids are going to be used for both rheumatoid arthritis and also for gout. So what is glucocorticoids? Glucocorticoids are basically the stress hormone called cortisol. Cortisol works in several ways. Let me just find my sheet here. Okay. So cortisol, what it does is it's going to stimulate body's release of amino acids from the body. So basically it's going to break down proteins. These amino acids can be broken down later on into glucose and energy because you're in a stress response, you need more energy. It's also going to stimulate the process of lipolysis to break down fat. Again, breaking down fat is going to help to increase your energy storage. It's also going to stimulate glycogenolysis, which is going to be the production of glucose from those amino acids and from those lipids that you use broken down from the fat. And also it's going to increase your blood glucose levels. It does this by inhibiting the glucose uptake in your muscle cells and the fat cells. So basically, glucocorticoids kind of artificially raise your blood sugar. So when you actually other hormones come in, your insulin perchance, will help to influx all those sugars back in your muscle cells so they have the energy they need to get in that stress response to get away. It's also going to strengthen your cardiac contraction because it's causing a stress response. Your sympathetic nervous system, as you know, causes an increase in your blood pressure, increase in your heart rate because it's stressing out your heart. It's going to cause you to get more oxygenation, more blood into your muscles so you can get away. Also, it leads to an increase in water retention. This is also important. And again, it also has an anti-inflammatory and anti-allergic effects. That's why we give it. Things to be aware of is that increased water retention and that cardiac overload can lead to CHF and other cardiac problems. The increasing glucose can lead to problems with diabetics. Even with people who are not diabetic, they will see an increase in their blood sugar, so you have to monitor the blood sugars and treat it appropriately. So your glucocorticoids basically that you're going to want to know, which we kind of covered steroids already, it's going to be prednisone, hydrocortisone, or methylprednisone. Basically, these are all just your steroid medications, and they work as what we said. So before you do anything, you want to get baselines of where they're at. Baseline vital signs of history, baseline blood sugar, are they diabetic, and what is their weight and what's their urine output. Their weight and urine output is important because remember we said it leads to water retention. That water retention is going to directly affect their weight. It's also going to decrease the urine output. So you want to make sure they're actually not just swelling up with fluid, and they're able to kind of monitor, control it, and excrete water out and manage it appropriately. Another thing that glucocorticoids do is they can lead to osteoporosis. They increase the calcium in your bloodstream. As I said earlier, remember calcium is used in your muscle cells. This is a stress response, so you need to your fight or flight is going to kick in. You need the calcium ions in the bloodstream so your muscles can have the calcium they need to contract. So what we're going to end up seeing is also lead to bleeding complications. So you're going to see risk for bleeding. You're going to see bone loss, osteoporosis. You're going to see weight gain from the fluid, from the water uptake. You're also going to see potential cardiac problems. You can see an increased risk for infection because it's also immunosuppressant and anti-inflammatory. So you have risk for infection. You're going to have those blood sugar levels are going to be really extremely high. And all these are going to be complications, but it's kind of the benefits outweigh the risks. Steroids are better used for short-term versus long-term. This is why when in the respiratory chapter they use glucocorticoids, they use inhaled steroids that are just localized to the lungs and hopefully technically won't cause as many systemic problems. These steroids for anti-gout and rheumatoid arthritis, these steroids are going to be used long-term and have systemic effects, which is going to lead to problems. Other thing you can be aware of is it can lead to Cushing's syndrome. Cushing's syndrome basically is the moon face. The moon face is basically the face swells up because the edema caused from the water retention. You also get the buffalo hump, the puffy eyes. Again, this is all just from the water retention. An increased in bruising and dizziness and a few other abscess, which is on that one slide of Cushing's syndrome. I'll let you kind of read through it on your own. But it's important to know what you're going to see. So if you have someone who's going to be taking a glucocorticoid, teaching is going to be key. You want to tell them to follow the prescription closely, and then also when they're on a steroid, they have to taper off their dose. So you need to make sure, even though for 2 weeks ago I was taking this for something else, I took 100 milligrams, but now they want me to take 50. That doesn't seem right. I'm going to take 100 again. Then you have to educate your patient and make sure they understand you have to taper down the dose so your body's own cortisol levels can be back to normal. Because when you artificially give someone a hormone, your body's going to naturally stop making that hormone, and you kind of got to let your body balance out. So you're going to want to, again, taper off the dose, report any muscle pain or weakness. That's going to be related to all the complications with the stress response and the hormones. avoid taking NSAIDs. Again, NSAIDs they're going to lead to potentially bleeding complications, which this can affect. You're also going to want to be aware of any sort of ingestion, black tarry stools, indigestion, and that's going to be your upper GI bleeds. Again, it's going to be signs of bleeding. You also want to be aware of any signs of infection, sore throat, fever, excess weight gain, edema. Are they going to be fluid overloaded? Do they have signs of what would potentially look as CHF, but it's going to be that water retention? And that water retention is going to lead to hyponatremia. Because remember, when you're retaining water, you retain sodium. When you retain sodium, you lose potassium. So the thing to be aware of when you're doing this is looking at your labs. You have hypernatremia. You're also going to have hypokalemia. So you got to be aware of what complications those are going to lead to. I think I missed something. I want to go back. I want to double check something real quick here. Sorry. Let me find the right note here. Alright. Never mind. We didn't cover the medication. Don't worry about it. Alright. Hopefully that kind of made sense. I was kind of all over the place. I apologize. But again, you can just pause the video, kind of rewind. Next is going to be endocrine. Endocrine, for us, is going to be largely diabetes mellitus. So one thing to be aware of is there's two diabetes mellitus, and this is diabetes insipidus, which are their different things. We're going to talk about diabetes mellitus in this class, and we're going to talk about the thyroid gland and what the thyroid gland leads to. So first is going to be your thyroid. When you have hypothyroidism, what's going to happen? You're going to see a high TSH and a low T3 and T4. TSH is your thyroid stimulating hormone. You have hypothyroidism. Your thyroid's not producing enough T3 and T4. Your thyroid releases those hormones. So your body is going to be releasing a lot of TSH trying to stimulate your thyroid to make more T3, more T4. It's not happening. If you have someone who's hyperthyroidism, you're going to see high levels of T3 and T4, and then low levels of TSH. You have low levels of TSH because your body is not able to stimulate the thyroid to produce the thyroid hormones because they're already overproducing them, leading to complications. So what is hypothyroidism? Hypothyroidism is basically called Hashimoto's disease. What you're going to see is things are going to be slowed down. You're going to see depression. You're going to see fatigue, weight gain, cold intolerance, constipation, decreased heart rate, blood pressure, and temperature, then dry skin and dry hair. Basically, it's going to be like a decreased metabolism. Things are going to be slowing down. If you slow down your metabolism, you're going to have lower heart rate, blood pressure, and temperature because that metabolic process isn't happening. On the flip side, you can have hyperthyroidism, which is called Graves' disease. This is going to be the exact opposite of hypothyroidism. So you're going to see heat intolerance, you're going to see stress, anxiety, tachycardia, hypertension, fevers. Another thing you can see is a lot of weight loss, a lot of GI problems. With constipation and hypothyroidism, you're going to see diarrhea with this one. Things are going to be moving too quickly. A unique thing to be aware of with Graves' disease is you can see ocular swelling. Basically, their eyes can bulge out. So the good way to remember some things is medication, hypo and hypo, usually be always inverse. If one thing does one, this is the opposite's going to do the other. So if hypo is this, hyper is going to be the exact opposite. That's how hypo and hyperthyroidism work. So we're going to give medications for hypothyroidism. We're going to want to try to supplement the lack of T3 and T4 they have. And how are we going to do it? Are we going to give them medications going to give them more thyroid stimulating hormone? No, it's not going to work. They already have an elevated TSH level. So what we're going to give them, basically give them a synthetic T3 and T4. We're going to give them synthetic thyroid hormones. By giving them the synthetic thyroid hormones, we're going to hopefully increase their metabolic rate, get them back to baseline. Things to be aware of is these again, hormones take a while to take effect. It'll take about a week for these medications to get them back to baseline. But you're going to want to assess for signs of hyperthyroidism because it could be taking too much. Excuse me. So you're going to want to monitor their vital signs, monitor their weight. Be aware of any sort of cardiac complications, because your cardiac complications are going to be related to tachycardia and hypertension. You're going to be stressing out the heart. You're also going to want to monitor T4 levels and TSH levels and make sure they're within normal ranges. Make sure you're not giving them stimulating them too much or not stimulating them enough. Also, hypothyroidism is basically going to be a lifelong treatment. Once your thyroid goes, it won't grow back. So you need to be on this medication for life to get their baseline. But at the same time, you're also going to want to assess for signs of hypothyroidism to make sure they're getting enough of the medication and not too little. So your main complication you want to look out for is going to be for your angina, assess for your hypertension, any signs of MI. It can also lead to renal disease. It can also lead to what's called a thyrotoxosis, which is a thyroid storm. A thyroid storm, basically what's happening is you overstimulate the thyroid too much. It kind of just goes into this crazy metabolic process and you overstimulate. It's kind of like, basically it's hyperthyroidism, basically what's happening. So otherwise, you're also going to lead to insomnia, because when you had the lethargy and depression and hypo and hyper, you're going to be causing them more alert. So when do I give this medication? I give this medication in the morning instead of at night. If someone's like, yeah, I can't sleep a lot at night. I don't know why I'm taking my Synthroid, but it doesn't let me sleep. Well, first you're going to ask them why they're taking it. If I'm taking it in the morning, I should be having too much. But take it at night, education is going to be key to get them to take it later on. Also want to monitor for your heat intolerance, tachycardia, hypertension. Also assessing their weight, because remember, this can lead to GI distress and diarrhea and weight loss. So we're going to want to treat that if it's happening. Alright. Next, what are you going to do if they have too much thyroid? They're going to have hyperthyroidism. There's a couple things you can do. First, you can give them what's called PTU, propylthiouracil, or methazole. These are basically going to help decrease the body's T3 and T4 and kind of get it back into a baseline. Sorry, I'm just looking for my notes real quick. So basically with these, what you're going to be doing is going to be blocking the synthesis of those thyroid hormones. You're going to block the T3 and block the T4. You're also going to block the oxidation of iodine. Something you need iodine. Your body is using the iodine to make the T3 and T4. This comes into effect with some other medications that can be used to treat hyperthyroidism. This is also why table salt is iodized, because your body needs a little bit of iodine. Granted, yes, if you do a lot of Google searches and read random articles on the internet, they'll say iodine is poisonous, yada yada yada, and not to take it. Have kosher salt. But again, if you take the little bit at a time that your body needs, it's safe and effective. If you don't give enough iodine, you can actually be causing yourself to have hypothyroidism by not getting that iodine. So, one thing I want to tell your patients with hyperthyroidism is not to potentially use that table salt. Use a kosher table salt, because you don't want them to have too much iodine, because they lead to iodine poisoning by eating too much, because things are already overstimulated. So what you can be watching for, if you're giving someone the polytropyluracil and methimazole, if you're treating it for hyperthyroidism, you want to look out for signs of hypothyroidism, basically causing, instead of one, you're going to cause the other. Other thing is, you want to give hyperthyroidism medications to someone who's going to be pregnant or lactating? No, because you're going to affect the thyroid of the fetus of the newborn baby. Also, these can increase the risk of bleeding, so any sort of bleeding complications of NSAIDs, warfarin, Coumadin, anything like that, also contraindicated. Next, what you're going to be used is Lugol solution. Lugol solution is basically a strong iodine and potassium solution that you're basically going to kind of overflood the thyroid. You're basically going to poison the thyroid with too much iodine, and so you're going to basically kill the thyroid tissue because it's hyperthyroidism. What's going to happen is you're going to end up leading them to have hypothyroidism. So their thyroid is acting up too much and you can't control with the other two medications. You're basically going to try to do a thyroid, not thyroidectomy, which would be removing the goiter from the thyroid because it's growing too large, but you're going to give them too much iodine, kind of poison the goiter, poison the thyroid, and kind of shrink it down. But again, remember, the thyroid does not reheal, so you're basically going to be killing that tissue. You won't be able to get it back. So what you're going to give them after this, you're going to be on Synthroid because they have hypothyroidism. So you give one to treat the hyper, but you're going to cause the other. With giving Lugol solution, basically what you're going to want to do is, this is going to be used before they have their thyroidectomy. So basically they're going to have their thyroid and the goiter removed. So you're going to decrease the thyroid size, decrease the function, and so your surgeon can go and remove it. Other thing to be aware of is, again, watch out for pregnant people, lactating, and again, you're going to be causing hypothyroidism. So after the thyroidectomy and after anything happens, you're going to need to give them on Synthroid. You have to monitor those signs and symptoms again. Alright. Lastly, we're going to talk about diabetes mellitus, probably the most common sign and symptom people ever know of. It affects your blood sugar. So what's happening? Again, this is going to be an autoimmune problem in type 1 diabetes, two types, type 1, type 2. In type 1, it's an autoimmune disorder that your body basically attacks the cells of the pancreas, decreasing the body's ability to create and secrete insulin. So in type 1, they don't have enough insulin to actually create what they need. And so you're going to need to supplement that insulin to help control their blood sugars. In type 2 diabetes, what you're seeing is either one of two things. One, they're not making enough insulin from the pancreas, or two, the insulin basically your body becomes resistant to it. So it's insulin resistant. It's like, we don't care. We've been hyperglycemic for so long, there's so much insulin in here, we don't know what to do. So with type 1 diabetes, there's only one treatment. That is going to be an insulin treatment. They don't have enough insulin, so you have to give them insulin at their body's expected baseline. Type 2 diabetes is non-insulin dependent diabetes mellitus. So they may not need insulin, they may just need an oral anti-diabetic or some other agent. You can end up giving insulin to a type 2 diabetic because maybe their body just doesn't have a way to properly forward insulin because your pancreas doesn't make it, so you can give them a little bit more. So generally speaking, your blood sugar should be in normal range between 60 to 100, 70 to 120. It's kind of, depending on the lab, there's a range of blood sugars you should be. Let's just focus on 60 to 100 for this class. So if your blood sugar is too high, what are you going to see? If your blood sugar is too low, what are you going to see? Basically, if it's too low, you're going to potentially, it's going to be the old adage, the little saying, cold and clammy, have some candy. Hot and dry, I can't remember how it goes. Basically, you're cold and clammy when you're low. You're going to be hot and dry and anxious and a little agitated when you're high. With low, you can also have confusion, delusions, hallucinations because your body doesn't have enough glucose. There's a cute little picture in the PowerPoint you can kind of go through the signs of hyper and hypoglycemia. It's very important to know what those are. Alright. Remember, hypoglycemia is going to be anything under 60. And so, how are you going to want to treat it? If someone has hypoglycemia, you want to give them, first, they don't have enough sugar in the bloodstream. So I give them a quick acting sugar, some sort of 4 ounces of some sort of juice. orange juice, raspberry juice, apple juice, some hard candy, something to get the sugar back in their bloodstream. Then also after that, go on a recheck in 30 minutes. If it's low again, give them something else. If it's high, they're fine. But after you get that quick sugar, give them that simple carbohydrate. You might give them a complex carbohydrate. You might give them a high protein snack or something a little more complex that'll slowly break down so they have more sugar control. And hyperglycemia is going to be treated with insulin. So, there's several different types of insulin. It's very important you know how to identify different types. You understand the onsets, the peaks, and the duration of each one. So the first one is going to be rapid insulin. These are all generally going to be, the brand name will end in log. Novolog, Humalog. These are going to be very quick onset, generally less than 15 seconds. Their peaks are going to be around 30 minutes to 90 minutes. It's going to be your peak. So your onset is when the insulin is going to have an effect and start to decrease your blood sugar. The peak is going to be the maximal potency of that insulin. It's going to have the strongest effect of lowering the blood sugar levels, and it's going to slowly go down, and that's going to be your duration. How long do they act? The rapid acting, they're going to have a quick onset, quick peak, and a short duration. Things to be aware of is you're going to give someone a rapid acting insulin, you need to give it right before they start eating. Once you start eating, it takes your body about a half hour to start digesting that food. So you give them their insulin, it's going to start to peak around 30 minutes when that food's digested and when their blood sugar is going to spike. So you're going to give it to kind of counter that spike. You can also give regular insulin. That onset is going to be at 30 to 60 minutes. Peak about 2 to 4 hours, and it can last 6 to 12. So again, with this one, as you're starting to see an onset, it's going to happen around that 30-minute range. So it's going to start to lower their blood sugar about at the same time that insulin starts to spike from their food. So, 4 questions. So there's a question about when you can give your insulin. If it's a regular insulin, you always go by your onset. You always give your rapid actings right when they start eating. You can give your regular insulins 30 minutes before they start. So if there's a question that says you're in the hospital, in your home, patient's tray is going to come in 30 minutes. Their blood sugar is 220. You're ordered to give 8 units of insulin. What do you do? If you're giving a regular insulin, you're going to give it right then and there. Don't overthink it. It's telling you the tray's going to come in 30 minutes. Don't think about real things. Well, the tray's going to come in 30 minutes, but it might not be 45 minutes, this and that. She's not going to want to eat yet. Tray comes, patient starts eating instantly. It's NCLEX world. It's perfect world. Whatever they tell you is what's going to happen. So if there's a question that says 30 minutes later, the tray's going to come, you give your regular insulin, that's when the onset is. If you're going to give a rapid insulin, you're going to want to hold and wait until that tray gets there because their onset's going to be quick. Alright, next is going to be an intermediate insulin, which is NPH. It's a 1 to 2 hour onset, 6 to 12 hour peak, and an 18 to 24 hour duration. NPH is what's considered your cloudy insulin. Your rapid and short insulins are going to be clear. I'm going to get into how to drop your insulins in a little bit. Lastly is going to be your long-acting insulins. This is going to be your Glargine and your Detromir, Lantus-Levemir. These medications don't truly have a peak. They're going to have an onset, but it's going to have an onset, and it's going to have a nice, steady duration, and then it's going to slow down. Basically what these do is these give nice, long, steady base control to help lower their blood sugar. Usually given twice a day. But they don't truly cause a hypoglycemic effect because they don't ever really peak. They're just going to give it slow little control. Rapid, short, and intermediate insulins can lead to hyperglycemia. Hypoglycemia. Hypoglycemia is going to happen during the peak. So if you have someone that's on NPH, remember their peak's going to be 6 to 12 hours. 6 to 12 hours after you give it, you want to make sure they're eating something that can counteract the effects of the potential hypoglycemia that's going to be happening during that peak process. So you're going to need to drop your insulin. How do you drop your insulin? Say you have an order to give 5 units rapid acting, 4 units of NPH. You just draw them up willy-nilly? No, there's a certain order you have to draw them out. Basically, you're going to want to put because you always got to put air into the bottle. So you put your air into your clear. So your clear bottle is going to be set. You're going to put air in your cloudy bottle. Oop. Actually, I think I said that wrong. Just a second. Okay, I had to kind of pause and rethink thing here. So what you do is you have to put your air into the vials first. You put your air into your cloudy. You put your air in your clear. You draw your clear, and then you draw your cloudy. So a good way to think about it is like a hurricane. A hurricane is always the eye of the storm is clear in the middle. That's when you do your clear insulin. It's cloudy on the outside, clear in the middle. So you put your air in your cloudy, and then you draw up your clears, because you don't want to get any of that cloudy insulin into your clear vial and contaminate it. If you get a little of the clear insulin in the cloudy vial, you're not going to have any real effects. You're not going to affect it so much. But you don't want to get that into that intermediate acting insulin into your clear vial. So you always put your air in your cloudy, air in your clear, draw your clear, then you draw your cloudy. It's important to know that rapid, short, and intermediate insulins can be mixed. The NPH vial is cloudy, so you never want to shake the vial. You want to roll the vial because you don't want to break up the molecules inside that NPH. Other thing to be aware of is your long-acting, your glargine and detramer, can't be mixed with other insulins at all. They are clear insulins, but they can't be mixed. Only your rapid, short, and intermediate can be mixed together. The other thing is you want to use different sites. Where you give the injection is going to affect the absorption rate. Generally, it's going to be a subcutaneous insulin, so it's going to be somewhere in some fatty tissue. Your abdomen, your arms, thighs, something like that. But you also don't want to use the same site over and over and over again. You can lead to scar tissue being formed. So you always want in your abdomen, you always kind of want to move around the abdomen, use different sites around the body. You don't want to use the exact same spot over and over and over again. Other thing to be aware of is going to be your anti-diabetics, your oral anti-diabetics for type 2 diabetes only. There's 5 of them. So basically what you want to know with your 5 oral anti-diabetics is, what are their side effects? What do they do? Well, one, they're all going to potentially lead to controlling your diabetes, but then some of them need to be given with food, some do not. Some can cause hypoglycemia, some cannot. So let's kind of go through them one class at a time. First one is the sulfonylureas. Sulfonylureas you want to take with food. It can cause a hypoglycemic effect. So you're going to want to give it with food so that when it starts to act, it's going to drop that blood sugar. They're taking something when they have incredible sugar intake when it's happening. Next is going to be metformin. Metformin is going to be the medication you're probably going to administer the most. It's the most used oral antidiabetic. But for this one, you want to be aware of that it's an oral antidiabetic. You need to take it with food, but it's not going to cause a hypoglycemic effect. This needs to be taken with food more for upset stomach, nausea, and vomiting. Other thing to be with metformin is it can lead to nephrotoxicity. It can lead to destruction of your kidneys. What other things are strongly potent on your kidneys? Contrast dye, going for a CT or an MRI. So there's always random NCLEX questions about giving your metformin for a CT or an MRI. it's going to be contraindicated because that contrast dye is going to be potent on your kidneys. So anything that's going to be strong against your kidneys, you don't want to give metformin with it. Next is going to be your thiazidones, the middle one. My print's a little small here, I apologize. For this one, again, you also want to be aware is this can also lead to nephrotoxicity, but hypoglycemia is not going to occur with this one. So again, you don't want to potentially, you don't have to give it with food. There's not going to be a hypoglycemic effect. Next one is going to be the alpha glucanase inhibitors. These are given with food not because they're going to cause hypoglycemia, but they're going to help control your blood sugar absorption and prevent the post-meal spikes of your blood sugar. Last one are going to be the megalodidine analogs. These also need to be taken right before your meals because they can also lead to hypoglycemia. So a good way to think about it is the first and the fifth one, the one on the side, are going to lead to hypoglycemic effects. So they have to be taken with food. Metformin is taken with food more for upset stomach. The alpha glucanide inhibitors are taken with food to help prevent the post-meal spikes. Even if they're type 2 diabetic and they're on oral anti-diabetic, it's still going to mean you're going to want to monitor your blood sugar levels to make sure it's having an effect. Otherwise, it's not going to work. Also, what can potentially happen with uncontrolled blood sugar is going to be what's called DKA, diabetic ketoacidosis. Basically, what's happening is your body's just flooded with sugar. Your body doesn't have enough insulin to absorb it. It's not getting absorbed, so your muscle cells aren't going to be using the glucose, so they're going to start breaking down the proteins for energy. The breakdown of the energy is going to be released as ketones in your body, which is going to cause acidosis in the bloodstream, leading to the diabetic ketoacidosis. Basically, with that, what you have to be aware of is getting large doses of insulin. Insulin also causes your cells to absorb potassium. So what you can give for hyperkalemia is going to be IV insulin. You're going to give them insulin because it's going to cause the cells to reabsorb the potassium. But when you give them that IV insulin, what you're also going to do is you're also going to lower their blood sugar. So you're going to give them an amp of dextrose 50. Dextrose 50% is basically sugar. So basically you're going to give them sugar to counteract their blood sugar levels when you give them the insulin. So insulin's only going to affect the hemodynamics of the potassium levels and not their blood sugar, because you can give them extra sugar to kind of counteract it. But if you're giving a lot of insulin, you're going to want to monitor kidney levels. And what do you do if your patient can't eat, can't drink, can't have a snack? You're going to give them a shot of glucagon. Glucagon basically is going to be a shot. It's going to be IM sub-Q injection. What glucagon does, glucagon is your body's natural hormone that causes the breakdown of glucose in the liver. So basically it causes the liver to break glycogen down to glucose. So if they're unresponsive, they can't eat anything, you're going to want to put food down their throat? No, they can aspirate. So you give them a shot of glucagon, it's going to cause their liver to break down the glycogen into glucose, thus increasing their blood sugar. But things to be aware of is going to take a while. You also want to be aware of that it can lead to hyperglycemia and break down too much sugar, causing the opposite problem. But then again, it's a lot easier to treat hyperglycemia than it is to treat hypoglycemia. Also, what you want to know is you want to be aware if it's an elderly woman who's about 80 pounds wet, she's not going to have a lot of glycogen stores on her body. So will glucagon probably work? Not really. She doesn't have a lot of glucose energy stored. Another thing to be aware of, if that's the case, you have to get in some sort of peripheral access, some sort of IV, central line, some sort of access into them, then you give them the dextrose 50 amp. You just give them an ampule, basically a large syringe of dextrose 50% into their bloodstream, thus raising the blood sugar. Other thing to be aware of with diabetes is generally they're going to come in for what's a fasting glucose level, where basically you're not going to tell them, like, please don't eat for 8 hours. We're going to test your blood sugar, see where you're at. Is your body able to control your blood sugar levels and keep it down? Other thing, that's a great test for how they're doing now. Maybe they were eating the appropriate diet, not having a lot of sweets and sugars, and having good control of their insulin. But what's a good chronic test of their diabetic control? That's going to be the test of their hemoglobin A1C. Hemoglobin A1C is basically the glycosylated hemoglobin of the blood, which needs to be on your slice less than 7%. Some things say 6.5. So I would probably go with 6.5 to 7%. I'd probably go with 6.5. So that 6.5 level is where you want. It's going to be good glucose control. What does that 6.5% mean? It's the amount of the hemoglobin molecule, your blood cell, that's covered in sugar. So basically what it's saying is 6.5% of your blood cell is covered in sugar. Everyone knows that the complications of diabetes are going to be peripheral neuropathy, blindness, tingling, pain, things like that. This all happens because the blood sugar levels are so high, the sugar actually begins to coat the inside of your cells. So what's going to be coating first? It's going to be your capillaries in your peripheral joints, your fingers and your toes. It's going to basically clot off those capillaries with sugar, leading to neuropathy and pain, and eventually diabetic ulcers, because that area of the skin is going to break down. The A1C is the measure of that level. Alright, hopefully this all made sense. If there's any questions, please come email me, talk to me. Also, it's very important you read your book. Some things we may not have covered, they can still be on the test, so it's important you read your book. Thank you. Have a good day.